Hello, everyone, and welcome back from your break. My name is Ron Turnaway, and I will be moderating the next session. Before we start, the ringmaster has asked that each of you complete the poll from the last session. If you take a look in the chat, there's a place for you to do your polls. So as I said, my name's Ron Turnaway. I'm one of the support group leaders for Atlantic Canada. Our Atlantic Canada group has about 45 members, including one who joined this morning. Welcome, Ken. And we're one of 8 support groups all across the country. So I encourage you, if you're not already a member of one of our groups, check out the website and come along and join us on Zoom. It'll be worth it. I also encourage you, next time you're in the lobby, to go to the section that says Meet the Experts and read David McDonald's curriculum vitae and those of all the other generous professionals that are with us here today and tomorrow. My story is a lot more personal. I met David McDonald 10 years ago when he was head of lymphoma clinical trials in Halifax. And if that hadn't happened, I would probably be pushing up daisies today and someone else would be introducing him. He expedited my delivery to a clinical trial that he'll be talking about as part of his presentation, where I was one of the first in Canada to get ibrutinib, and the last of 31 patients worldwide to be on that trial. So I am eternally grateful to David. The other thing I want to tell you is a year ago, he met with us on Zoom, a national meeting for the WMFC, where he talked about Waldenstrom from its origins to current treatments and beyond. And in my 17 years as a Wally, it's the finest presentation that I've seen explaining Waldenstrom's. It's the most popular video on our YouTube channel. I encourage you to take a look. And without further ado, welcome David McDonald.
Thanks, Ron. That's very generous. And you know, I've been in Ottawa now for 6 years, and I've never forgotten the trial and never forgotten meeting you. And I think taking over your care from one of my colleagues, and it's a real success story. So it's a pleasure to be here. It's a pleasure to see you again, and I'm really glad to be able to talk to the Waldenstrom's group today. So I was asked to talk about current and future treatment options. So Ron will see some of the information that I talked about a year ago, but of course there's much more updated information than that. Next slide really is often referred to as the objectives slides, but I'll call it the ask slide. So Rafaela sent me sort of these points as the things that she wanted me to cover. So current standard treatments for frontline, current standard treatments for relapse patients, talk a little bit about watch and wait, and I know in the previous session you had a little bit of discussion about that in the questions and answers. I'll talk about clinical trials and then what's out there and how you can find them. I will touch a little bit about variability in what's available in different regions in Canada, and I'll even highlight the process, the behind-the-scenes process about how we get medications like ibrutinib available for patients. So at the end, I'll try to bring it all together, and hopefully we'll cover all of these points. So I am going to start with watch and wait because it still is a thing for sure. We recommend watchful waiting for patients who are asymptomatic. You can see there in the left-hand part of this slide, this was a study that was presented in 2001, and it looked at 217 patients who had a new diagnosis of Waldenstrom's. And the point of the study was to talk about which of the symptoms really are the things that lead to the diagnosis when patients are first presenting. So things like anemia, hyperviscosity, B symptoms that we'll talk about, bleeding problems, neurologic problems. But in this study of those 217 patients, 27% of them really had no symptoms at the time that they were diagnosed. That sort of leads into a concept of smoldering Waldenstrom's, which isn't really smoldering Waldenstrom's, it's Waldenstrom's that is asymptomatic. So it's defined as patients with an IgM level which is at least 30 grams per liter. So this is not IgM MGUS, this is Waldenstrom's. So either IgM of 30 grams per liter or at least 10% of the bone marrow is involved with lymphoplasmacytic lymphoma cells, and they have no symptoms or reasons to treat at the time that they're diagnosed. And so this study by Kyle that was presented in 2012 really gives a nice explanation, which I really think is important when people ask the question, I have asymptomatic disease, but I have this disease, it's a cancer, so why would you consider watch and wait? Why not treat it right away? And that really is highlighted by the number of patients that don't need treatment over time. So you can see here that in this study, only 6% of patients needed treatment in the first year. So again, these are patients with Waldenstrom's and no symptoms at the time that they're diagnosed. Even at 3 years, only 39% of patients have needed treatment. At 5 years, only 59%. And by 10 years, only 68% of patients have needed treatment. So if you look at the flip side of that, that means that 32% or 1/3 of all of these patients that had no symptoms can be watched without treatment for at least 10 years. And so, a very good rationale for not providing treatment up front is that 1 out of 3 patients, you will deprive them of that 10 years where they have no symptoms of their Waldenstrom's, they don't have to have any side effects of treatment, and they can avoid that treatment for that time period. So watch and wait is, of course, still a thing. Now, I think you probably talked in the previous session about the reasons to start treatment. So we try to formalize these. This is the International Waldenstrom's Working Group definition of the reasons for treatment. And there's two parts of, when you see a list like this, there's two parts of it. One is who has symptoms that needs treatment. And the second is when you're doing a clinical trial of first-line treatment in Waldenstrom's, if you're studying a population and a large proportion of that population has no symptoms, as I've just shown, 32% of those patients with no symptoms could go 10 years without ever needing treatment, meaning they would go 10 years without progression. So when we do randomized trials of Waldenstrom's in first line, we want to avoid including patients who don't have any symptoms, because those patients could potentially bias or skew the results in favor of longer progression-free survivals, for example, because you're treating patients that may otherwise not need treatment. So anyway, back to the list. So constitutional symptoms, including night sweats that are drenching, fevers, unexplained weight loss. Those are what we sort of refer to as the B symptoms, or the constitutional symptoms. And if they're present, then that probably is an indication to treat. Low blood count, so anemia with a hemoglobin less than 100, or thrombocytopenia with a platelet count less than 100, those would be indications to treat. Large lymph nodes or spleen. I should say large symptomatic lymph nodes or spleen. So a normal spleen size on a CT scan may be 13 centimeters as the upper limit of normal. Somebody could have a 14 centimeter spleen, which is technically enlarged. It may be the only thing that's present that would be on this list as a reason to treat. And if it's completely asymptomatic, then I would say that person doesn't actually necessarily need to be treated until that becomes symptomatic. So hyperviscosity symptoms, I think you probably spoke a little bit about what those types of hyperviscosity symptoms are. We tend not to see hyperviscosity in patients who have an IgM level of less than 40 grams per liter. I overheard a question about serum viscosity. So hyperviscosity means high serum viscosity. One of the problems with the serum viscosity test is that it's really unreliable. If you do a viscosity test in the same patient on 2 consecutive days, you can get very different results. So I tend not to use viscosity as a test to tell me that somebody needs treatment or not. Cryoglobulinemia, I know that you talked about before. Cold agglutinin disease, this is where you have the IgM, the monoclonal IgM is causing red cells to clump together, and then that triggers the immune system to break down those red cells, and you develop a hemolytic anemia. That's cold agglutinin disease. Moderate to severe neuropathy certainly is a reason to start treatment in Waldenstrom's. We talked about that before. And amyloidosis is sort of a severe complication of Waldenstrom's that really can be quite devastating, and thankfully it's not very common. So this just highlights what those hyperviscosity symptoms can be, and really viscosity is blood flow. And so if you think about blood flow in different parts of the body, what can happen if that's impaired? So if you have poor circulation in the limbs, for example, you may get Raynaud's phenomenon, you may get leg ulcers that don't heal very well. Poor circulation in the brain. So many patients with Waldenstrom's present with headaches, and that may be related to hyperviscosity. Some even present with strokes or mini strokes, and cognitive problems can occur in patients who are having sort of recurrent silent mini strokes, but over time are accumulating damage that can cause problems with cognition. Hyperviscosity in the eyes can cause an acute problem with retinal hemorrhage or retinal occlusion, and that can lead to visual problems. And Dr. Pickering talked about plasmapheresis or plasma exchange. That would be one of the indications for urgent plasma exchange, to very quickly bring the IgM level in the blood down from something very high to something very low, to prevent further visual problems. And then, of course, amyloidosis, deposits of IgM in the skin, nerves, or heart can cause end organ damage. So these are pictures that are not that easy to look at. Well, Raynaud's phenomenon, I think you've talked about before. So it's a characteristic change in the color of the skin, red, blue, and white. And in an individual, it usually follows the same sequence each time that it occurs. On the right-hand side there, you have a non-healing leg ulcer. So that's a problem with microcirculation in the leg. The nutrients can't get to the site of the ulcer, and therefore the ulcer doesn't heal very well. So we'll start to talk about standard first-line treatments of Waldenström's in Canada, and I'll talk about in Canada and outside of Canada a little bit as well as we go through these. So the first important sort of thing to define is, what do we mean when we say standard of care? So the standard of care when we're treating cancer is a treatment that has been established as being the best treatment, and there are different criteria that may define what is the best. It could be the most effective treatment, or it could be the most effective treatment that is tolerable. In other words, if a very effective treatment causes a lot of side effects and even fatal side effects, then maybe it's not necessarily the best treatment. So how do we come about what is our definition of standard of care? Well, the best evidence is randomized trials. So if we say that at this time point, R-CHOP is the standard of care for Waldenström's, in order to change that standard of care, we would have to have a randomized controlled trial of something else compared to R-CHOP. And if that something else shows to be either better, more effective, or less toxic, then it can become the new standard of care. And so a randomized trial of bendamustine and rituximab BR was conducted against R-CHOP. The BR was the better treatment, both in terms of efficacy and also in toxicity, and therefore BR became the new standard of care. So the best way to define standard of care is through randomized controlled trials that compare a new treatment to an old treatment and prove that the new treatment is better. The problem with that in diseases like Waldenström's is that there are not enough patients to do a randomized controlled trial easily. And so the next best level of data would be single-arm studies that are specifically done in Waldenström's patients. So phase 2 studies of, for example, ibrutinib plus rituximab. Take a cohort of patients, maybe 200 patients with Waldenström's, study them all, treat them all exactly the same way, and then look at the results. And then say, okay, well, in this group of frontline treatment with ibrutinib and rituximab, the number of patients that responded was X, the length of the remission was Y. And if you look at the current standard of care, the ibrutinib and rituximab seems to be better. Now, it's not a randomized study, so it doesn't actually prove that it's better. But again, in a rare disease, sometimes a phase 2 study or a single-arm study is enough to convince Health Canada or the FDA that new treatment is a better treatment. And then the next sort of best evidence to establish what is standard of care in Waldenström's is to take a similar disease, follicular lymphoma, where there are a lot more patients, maybe 5 times more patients with follicular lymphoma in Canada compared to Waldenström's. Do a randomized trial in those patients and say, well, Waldenström's is a very similar disease to follicular lymphoma. So if treatment X works better in follicular lymphoma, it may also work better in Waldenström's. But you can see why that's not as good data as doing this study directly in Waldenström's patients. So we will talk about the types of cancer treatments, and I think, what you're all probably thinking now is, I don't want chemotherapy. I want something that's a chemo-free option. I want immunotherapy because I've read about immunotherapy. It's a very popular topic to discuss. And I want targeted therapy because that's very specific for my cancer. So chemotherapy, I think of sort of as the bombs. The way it works is that it causes cells to die, but it can't distinguish a cancer cell from a normal cell. If it works more on cells that are dividing, then it'll work more on cancer cells because they divide more often than normal cells. But there are innocent bystanders, and that's the reason that chemotherapy is toxic. It's the effect of the effect of the treatment on the innocent bystanders that causes the toxicity. Immunotherapy is treatment that takes advantage of the body's own immune system to fight cancer. We have one of the roles of our immune system is to fight infection, of course, but another important role of our immune system is that all the time in our body we're developing abnormal cells that are cancer cells that have mutated when a normal cell has tried to divide. And the body needs a mechanism to try to eliminate those cells from the body. That's the immune system. And actually the immune system is very good at fighting cancer. However, when lymphomas like Waldenström's develop, sometimes those cancer cells have developed a way to avoid the body's immune system. So immunotherapy is a way to enrich the immune system and improve its ability to attack the cancer. So a perfect and very simple example is rituximab, very commonly used in all lymphomas, including Waldenstrom's. It's an antibody, a monoclonal antibody against CD20. CD20 is a protein that's on the surface of the Waldenstrom cell. So when you inject rituximab, it attaches to the cancer cell. And when something in the body is attached to an antibody, that triggers the immune system to remove it. So I'll talk about more modern immunotherapies like stem cell transplant, like CAR T therapy and bispecific antibody therapy a little bit later on. And then I'll just go back 1 second for targeted therapy. Targeted therapy would be things like ibrutinib. So these are usually small molecules. They're usually given orally, and they're targeted against specific pathways that are regulated in the cancer cell. So if you have a pathway in a Waldenstrom cell that is upregulated and it results in increased cell division, if you can target that pathway and interrupt it with a targeted therapy like ibrutinib, then that can be effective and more specific to the cancer cell than to non-cancer cells. So again, the standard of care first-line treatment for asymptomatic patients is watch and wait, and we had those two studies on that previous slide. In the first one, 217 patients, 27% of them had no symptoms. At 3 years, 50% of them still didn't need treatment, and at 10 years, 10% of them still didn't need treatment. In the later study, it was 32% not needing treatment at 10 years. Why the difference? Well, those studies were published 10 years apart, and our ability to identify Waldenstrom's better through serum protein electrophoresis and through flow cytometry means that we're diagnosing more patients with Waldenstrom's at an earlier stage in their disease. So patients with asymptomatic Waldenstrom's may be detected much earlier than they were just 10 years before, and you can see that reflects in how well people are doing with time. So who should be treated? We talked about this, so that's the list of symptoms that requires treatment. I want to make the point that we don't base our treatment decision on the level of IgM. So there'll be many patients who are diagnosed with Waldenstrom's who know that their IgM level is, for example, 25 grams per liter. And every time they come and see their oncologist, they recheck their IgM level and they're watching it rise. So now it's 30, and now it's 35, and now it's 40 grams per liter. And a very common question that I get is, how high is too high? At what point do we say, okay, that's the cutoff, and now we're going to start treatment? And truly, there is no cutoff. I have many patients with an IgM level of 10 and a lot of symptoms. They need treatment. And I have other patients with an IgM level of 50 and they don't have any symptoms and don't need treatment yet. So we don't base our treatment on the IgM. And then a point about plasma exchange or plasmapheresis. So plasma exchange is a very good way to quickly reduce the IgM level. It's almost like dialysis. You connect somebody to a machine through intravenous. So your blood circulates from your vein through the machine. It gets filtered, the IgM gets removed, and then the blood returns to the body through another vein, just like dialysis. And you can bring your IgM level down from 50 to 10 in 2 hours using plasmapheresis, but that's not a treatment because the problem is that the cancer cell, the lymphoplasmacytic lymphoma cancer cell, is continuously making that IgM, and so this is a very temporary benefit. So it's used in acute situations, for example, like retinal hemorrhage, and it's used sometimes before we start rituximab-based treatments, because the rituximab studies early on showed us that if you had somebody with a high IgM level and you gave them rituximab, it actually flared and went higher before it went lower, and that could trigger neurologic problems or other hyperviscosity problems. So we use plasmapheresis sometimes in patients if their IgM level is over 40 before they get their first dose of rituximab, and we use it sometimes in acute situations to bring the levels down. So what are our standard first-line chemoimmunotherapies? Well, as I said before, they're borrowed from follicular lymphoma. There are a lot more patients in follicular lymphoma, and clinical trials were done in follicular lymphoma earlier than they were done in Waldenstrom's. So treatments like bendamustine and rituximab, or R-CHOP, or R-CD, or even single-agent rituximab, all of those were developed in follicular lymphoma and then applied to patients with Waldenstrom's. So this is a table that just goes through several clinical trials that looked at different chemotherapy regimens and their results in patients with Waldenstrom's. So I'll just go through the columns from left to right. So the first column is the name of the drugs in the trial. The second column looks at the number of new patients or the number of relapse patients. So for example, in the first trial there were 16 newly diagnosed patients, 13 relapse patients. The next column is the overall response rate. The next column is the major response rate. And I can come back to that and define it if it's a question later. The second last column is the rate of very good partial remission or better, meaning either complete remission or very good partial remission. And that right now seems to be the target when we design clinical trials. That's the column that we're really looking at, because you can see if you use overall response rate as your measure of success, well, almost everything has a very high overall response rate, but not everything has a very high VGPR or better rate. And then the most important column from my point of view is the final column, and that's the progression-free survival in months. So the median number of months for people to progress. How's that defined? Well, if you have 100 patients, over time people are going to start to progress, some people early, some people later on. When you reach the 50th person out of that 100 that has progressed, that's the median progression-free survival. So you can see that that's measured there in months. If you look at the little triangles on the left, that's a randomized trial. So there are two different randomized trials there. One is CHOP versus R-CHOP, showing that adding rituximab to chemotherapy certainly improved results. And the other one was the one that I mentioned, is the randomized trial of BR versus R-CHOP, which has established now bendamustine rituximab as our standard of care, first-line chemoimmunotherapy. You can see here, though, in the bottom row there, that's a different study that had 257 patients with Waldenstrom's. That's the largest study that we have. It's a randomized trial, but it's not a trial of one frontline treatment versus another. That was a trial of maintenance versus no maintenance. So in that study, it was newly diagnosed patients. Everybody received BR, and then those who had at least a partial remission were then randomized to either continuing on with rituximab maintenance for 2 years or no further maintenance. But the important thing of that trial is a very large trial. It shows a very high overall response rate and a very good median progression-free survival of 65 months. This is how we look at the randomized trial of bendamustine rituximab versus R-CHOP. So this is what we call a Kaplan-Meier curve, looking at the proportion of patients that progress over time. So in that graph on the left, what it's showing is that as months go by, more and more people are progressing, and when they progress, then the line goes down. And so as an oncologist who looks at these trials to decide if one treatment is better than another, what I want to see is a wide separation between those curves, and that's exactly what we see here. So the top curve is the curve for bendamustine and rituximab, and again, the median progression-free survival was 69 months compared to only 28 months with the R-CHOP. So these curves here are not from the entire study. The entire study looked at many different types of indolent lymphomas, but this curve here is for the subgroup on that study that was Waldenstrom's alone. And so BR was better than R-CHOP, dramatic improvement in the length of remissions, and it became the standard of care. So what about maintenance rituximab? Well, that study that I mentioned, the MAINTAIN study, actually did not show any improvement with 2 years of maintenance rituximab after BR. So in that study, whether you had maintenance or not, there was no difference in progression-free survival and no difference in overall survival. So maintenance rituximab is available in Canada. It's approved for all of the indolent lymphomas, and it's approved based on a randomized trial that was done in follicular lymphoma that showed that 2 years of maintenance after chemotherapy can prolong the remission by 2 years. But as it turns out now, we realize that that isn't the case in Waldenstrom's. And so the 10th International Waldenstrom's meeting consensus guidelines did not recommend maintenance rituximab. Still available in Canada. There are still people who I think are using it in Waldenstrom's, but again, not recommended by those consensus guidelines. So back to those people who desire chemo-free treatment up front, what about single-agent rituximab? It is an available treatment for Waldenstrom's. And it's used again in an effort to avoid exposing people to standard chemotherapy. These are a couple of studies, though, that I think would convince me that it's not very good. It doesn't work very effectively. So the first one was 69 patients with Waldenstrom's who haven't been previously treated. They received a dose of rituximab once a week for 4 weeks. The response rate was only 52%, and the average length of response was only 2 years. So again, compared to bendamustine and rituximab, these are not good results at all. Similarly, in a randomized study of ibrutinib plus rituximab versus rituximab alone, if you look at the patients treated on the rituximab alone arm, They had once a week for 4 weeks, and then 3 months later that was repeated. So that was a total of 8 doses of rituximab. Again, though, the response rate was like 50%, and the average length of response was only 2 years or less. So it's a useful treatment. 50% respond, and the remissions last for a couple of years. But then they're right back to needing treatment again. And one of the problems in Canada is that in many provinces, if you give rituximab to a patient, whether you give it alone or with chemotherapy, if that patient then relapses within a short period of time, then the province may not pay for rituximab again in their second-line treatment. And we do know that adding rituximab to chemotherapy does significantly improve the benefits of the chemotherapy. So for that reason, I tend not to use it. And that's, I think, what I've just said there in my personal opinion on rituximab. So then, to summarize that previous section, then bendamustine and rituximab is the standard frontline treatment for follicular or for Waldenström's. So what about standard treatments in relapsed patients in Canada? This is where it gets a lot more complicated. So there is no standard of care. That's the easy thing to say. And I think if you did a study and you polled 100 patients with Waldenström's and asked them what their treatment history would be, I think you'd find that many of them had the same first treatment, but there was a lot more variability in their second treatment and beyond. So historically, in patients with relapsed indolent lymphoma, when we're choosing what their next therapy is going to be, these are the types of things that we think about. How long did the remission last with the first treatment? What kind of side effects did they have with that first treatment? And have they developed any new problems? They had a heart attack or stroke or developed some other neuropathy or something that would then influence, the treatment that you would choose in their second line. And so for patients who had previous chemoimmunotherapy, let's say we took somebody who had Waldenström's diagnosed 15 years ago. In Canada, their treatment probably would have been either RCVP or RCD. Now, P is prednisone, D is dexamethasone, so that's just changing one steroid for another. But the V is vincristine. Vincristine can cause peripheral neuropathy. Peripheral neuropathy is a common problem in Waldenström's, so sometimes we will try to avoid using vincristine. So patients who previously had RCD, for example, or RCP, you might now treat them with bendamustine or rituximab because they haven't been exposed to bendamustine before. And the fact that they're relapsing for the first time after RCD means that their previous treatment was many years ago and it was very effective. So the concept of chemoimmunotherapy worked very well in that patient. We don't want to give them the same treatment necessarily. We have bendamustine and rituximab, they haven't received it before, it would be a perfect option for that patient. Conversely, though, somebody who maybe was diagnosed 7 years ago and had bendamustine and rituximab as their first treatment, if they had very few side effects and they had 7 years of remission, then it might be very reasonable to give them bendamustine and rituximab again. And we do know that it works again when it's used a second time. Typically, though, it doesn't work quite as well. So the remissions are somewhat less likely to be very good remissions, and the length of the remission second time around is usually shorter than the first time around. But the way that we sort of conceptualize reusing chemoimmunotherapy is that if it's a long first remission, then it's worthwhile doing it again, because then you can save your other treatments for down the road. So you might retreat them with BR again, or you might switch them to RCD, for example, or R-CHOP. I have R-CHOP there, but I wouldn't actually use R-CHOP. I would leave out the O in R-CHOP, and it would be R-CHIP or RCD. But I think we're now, obviously, we know more about Waldenström's and we have better treatments available. So I want to talk a little bit about MYD88 and CXCR4. I know that it was brought up in the previous discussion. MYD88 is a protein that is involved in the signaling of signals through lymphocytes, and those signals can be turning on cell production or turning on cell survival. MYD88 is mutated in 90 to 95% of patients with Waldenström's, and so in those patients who have a mutated MYD88, it's actually hyperfunctional. So the protein is mutated, but it works better. The mutated protein works better than the normal protein, and so it turns on signals that keeps the cell alive. It turns out that of the patients who do not have a mutation in MYD88, which is the minority of patients, they don't do as well. So how does that make sense? Well, if you have a mutation that turns on production, then if you have a target that you can hit, or if you have something that can hit that target, then the prognosis will actually be better. Furthermore, if you have a mutation that turns on cell production, then it makes the cell more sensitive to chemotherapy, to typical chemotherapy. So that's MYD88. CXCR4 is mutated in a smaller proportion of patients with Waldenstrom's, but patients with mutated CXCR4 become resistant to chemotherapy. So this is just a study showing a group of patients with Waldenstrom's and looking at their survival. This is not progression-free survival. This is how long they lived, overall survival, based on their mutational status. So you can see the blue, the patient at the bottom, or the curve at the bottom, those are the minority of patients who have a normal MYD88 and a normal CXCR4, no mutations. And then the middle curve is patients with a mutation of MYD88 but normal CXCR4. They do much better, they survive much longer. And then patients with mutations of both actually turn out to have the best survival in this study. So ibrutinib is a medication that's been around now for 10 years or more, developed in chronic lymphocytic leukemia. It's a medication that inhibits Bruton's tyrosine kinase, so BTK. So it's a BTK inhibitor. BTK is a protein that's again involved in signaling within the cell, and those signals lead to cell division or cell survival. And blocking that BTK protein within that cascade of signals has been proven to be effective in CLL first and also now in other lymphomas. And it turns out that in Waldenstrom's in particular, the mutation of MYD88 makes Waldenstrom's even more sensitive to BTK inhibitors even than CLL, where it was first developed. So this is just a sketch showing the mechanism of action. So you have these protein cascades that I talked about, and at the bottom of the cascade you can see either survival or transcription. So if the BTK is mutated, then it's turning on the signals for survival, making that cell last longer, and therefore if it's a mutated cancer cell and it has improved survival, then that means it's more resistant to cell death. And then it's also turning on transcription, which is reproduction of that cell. So now you have a signal for the cell to divide and a signal that prevents the cell from dying. You have an immortalized reproductive cell. And so BTK is involved. If it's mutated, it turns those signals on, but if you can block that with the BTK inhibitors, ibrutinib, acalabrutinib, or zanubrutinib, then you can turn that signal back down and make that cell behave as one that should die when it's expected to die. So what about the studies for ibrutinib in Waldenstrom's? So the first study was PCYC 1118. PCYC is Pharmacyclics. That's the company that first developed ibrutinib. There were 63 Waldenstrom's patients in that study. They were 63 years old. They were all pre-treated. So most of the patients had 2 prior treatments. And again, in general, when you're treating a cancer, you have the highest response rates with the first treatment. Then each subsequent treatment, we expect that the response rate is going to be lower. But in this study of patients that had at least 2 prior treatments, the response rate was 90%, which is really quite good. And then the very good partial response rate was 73%. Now we haven't reproduced that. That's a phenomenal number, but that was really very good. And perhaps most importantly, 69% of those patients had a remission that lasted at least 2 years. So that was in relapsed patients. Now, the PCYC 1127 study, this is a study that Ron was part of. It was a much more complicated design. It had 3 arms. I'll come back to arm A and B later, but arm C was a arm for patients with Waldenstrom's who had relapsed after rituximab in the past. So again, those are going to be patients who are a little bit more resistant to standard treatments. The response rate again was 90%. The PR or VGPR rate was 77%. And 60% of those patients were still in remission at 3 years. So this was very good results. And in fact, this study was published in the New England Journal of Medicine, which, for those who know, to get a randomized clinical trial published in the New England Journal, it has to be a landmark study. So what is the problem with ibrutinib? Why don't we just give it to everybody? Well, there are side effects, of course. And then again, this, a little bit I talk about those who prefer a chemo-free regimen. Ibrutinib is a targeted therapy. It's not traditional chemotherapy, but that doesn't mean it doesn't have side effects. And I just always remind patients of that. So low platelets or neutrophils, atrial fibrillation happens with ibrutinib probably in 10 to 15% of patients. Bleeding can be an issue, and everybody on ibrutinib has some amount of bruising. And then there are the side effects that I refer to as the nuisance side effects. That's things like rash, diarrhea, muscle and joint aches. These are the things that we can treat, but they certainly affect quality of life of patients. So back to the PCYC 1127 study. Remember, it was a complicated study. So arms A and B, this was a randomized study, but it included both patients who were newly diagnosed and patients who had previous treatment. So that makes the results a little bit more difficult or complicated to interpret. But the bottom line was it was comparing ibrutinib plus rituximab versus rituximab. Now remember I said I'm not really convinced that rituximab is a very good treatment for patients that have not had any previous treatment. So to choose that as the standard arm in this study, for me in Halifax at the time, I was preferentially putting relapsed patients onto this study because I thought that they had more to gain from the ibrutinib plus rituximab arm. But newly diagnosed patients were still on the study. And if you look at that arm B side, you can see that the response rates and the length of remission was the same as in the other studies that we talked about before. But when you use ibrutinib with rituximab, you had overall response rate of 95%, and you had almost 80% of patients still in remission at 2.5 years. And again, that includes newly diagnosed patients that you would expect to have a very good response, but also relapsed patients that were having a very good response as well. So how did ibrutinib do in Canada then after these two studies? So the first study, the PCYC, what was the number? I don't remember, 1118. It was published in 2016. Health Canada took that study and they evaluated it and they said, yes, Health Canada, we are approving ibrutinib for patients with relapsed disease. And then the other study, the PCYC 1127 study, first published in 2019. And again, Health Canada said, yes, we are going to approve the combination of ibrutinib plus rituximab. And the study did both newly diagnosed and relapsed patients. Therefore, that will be the indication. So Health Canada has approval for the combination ibrutinib rituximab for newly diagnosed or for relapsed patients. So that's Health Canada, but that doesn't mean that the drug is going to be available in the provinces. Each province has to make a decision about whether they're going to fund the drug or not. And that process is the CADTH P-CODER process. So they looked at the ibrutinib single agent study, the PCYC 1118, and they said, no, we're not going to recommend funding of the study. It had no comparator. It was a single arm study. So sure, patients did well, but how do you know they wouldn't have done well with other things that might have been available at the time? For example, bendamustine for patients that had never had bendamustine, or bortezomib, Velcade, which was an available treatment for Waldenström's at the time. So they said it had no comparator, and we think that there are enough Waldenström's patients that you can do a randomized trial. Therefore, we're not going to recommend funding ibrutinib until you do that and prove it. And then furthermore, they had no idea what the cost effectiveness might have been with single agent rituximab or ibrutinib. So it did not get funding. And then in 2019, when PCYC 1127 was published, Janssen, who had the rights to ibrutinib at the time and still do, they didn't even apply for funding with CADTH because the same arguments would have been made based on that study that it wasn't sufficient to get funding. So there is no recommendation from P-CODER to fund ibrutinib in Canada. So how is it available? Well, because it has Health Canada approval, I can prescribe it. I'm allowed to prescribe ibrutinib for any Waldenström's patient, but the problem is that if I give you a prescription for ibrutinib and you take it to the pharmacy, your pharmacy will give you a 1-month supply and an $8,000 bill. Now we got to figure out who's going to pay for that $8,000. And so Janssen has made it available to patients with Waldenström's through a compassionate access program with Janssen. And as far as I know, that program it still exists. So for patients with relapsed Waldenström's, you can get ibrutinib. It's not funded by any province in Canada, but Janssen will make it available through their compassionate access program. Now, what about newly diagnosed patients that are wanting to avoid chemotherapy? Can we get them ibrutinib and rituximab together? It's Health Canada approved. The answer is probably not. Private insurance is not going to cover it because provinces don't cover it, and with the added cost of the ibrutinib and the rituximab, it's probably not worth their while to do that. And for compassionate access, the problem here is that you have to apply to Janssen for compassionate access to the ibrutinib, and then you have to apply to one of the makers of biosimilar rituximab to get compassionate access to that. If you get that and it's intravenous, you can't give it in a publicly funded hospital, so you have to give it in a private infusion clinic, and so it becomes very cumbersome. So I would say for most patients, this is not going to be a first-line option. Okay, what about other BTK inhibitors? So again, I talked about the problems with ibrutinib being its toxicity and cardiovascular toxicity and bleeding being the main thing. And the reason those toxicities occur are because even though it's a BTK inhibitor, it also acts on other proteins. So it also interferes with other processes that are going on in normal cells, what we call off-target effect. So the newer BTK inhibitors, acalabrutinib and zanubrutinib, they've been designed to be more specific or more targeted. So they target more specifically on BTK, and they have less off-target effects on other targets, and therefore less toxicity. So that was the goal of developing acalabrutinib and zanubrutinib. And now we have a third generation of BTK inhibitors, which I'll describe a little bit more later with a diagram, but these are called reversible non-covalent inhibitors, and they actually work in patients who have had ibrutinib or acalabrutinib or zanubrutinib, but have become resistant to that through a certain mechanism, which I'll show. So these are called kinase maps, and they just show what it was that I was talking about. So each dot is a protein that's being acted on by the agent. The blue is the BTK. So what you want ideally is to have a large blue circle and no red circles. But the red circles are all the other things that are being targeted, and the size of the circle, it has to do with how much of that target is inhibited, so what the effect is. So you can see here that acalabrutinib and zanubrutinib in these diagrams show fewer and smaller off-target effects, and so theoretically they should have fewer side effects. So there has been a randomized study comparing zanubrutinib versus ibrutinib in Waldenstrom's, and the goal of the study was to show that it was safer, that it had fewer off-target effects and therefore less toxicity, but also to look at how effective it was because it is a more potent molecule. And so this study, it included a relapse group, but also a treatment-naive group, so a group of patients that had not had prior chemotherapy. But because the standard arm in this study would be ibrutinib, and ibrutinib was not available for those patients, to be eligible for the trial as a frontline patient, you have to be unsuitable for chemotherapy. Basically, it shows that the response rates are about the same, 90 to 95% across the board. But the proportion of patients that had a deeper remission was much better with zanubrutinib at 28% versus ibrutinib at only 19%. So this was the ASPEN study, and it showed that zanubrutinib is probably a better treatment than ibrutinib in Waldenstrom's. There were different profiles of toxicity, so side effects that were more common with ibrutinib were diarrhea, muscle cramps, peripheral edema, bruising, and respiratory infections. The side effects that were more common with zanubrutinib were constipation, nose and throat infections, some back pain, shortness of breath, and low neutrophils. So you can see that the molecules, even though they're the same class, they have different effects. So what about the access to zanubrutinib? So in 2021, when the ASPEN study was published, Health Canada approved zanubrutinib for Waldenstrom's. And because the study included treatment-naive and relapsed patients, again, Health Canada approved it in both those categories. CADTH reviewed this in December of 2021 and recommended that zanubrutinib should be funded for relapsed Waldenstrom's. They didn't necessarily recommend that it should be available for frontline, and again, because there's no comparison to chemoimmunotherapy, which we know can work very well. So from the time CADTH said, yes, provinces, you should fund this drug, until the time that it became available this year in Ontario and in most provinces, it has been available through a patient support program by BeiGene, the company that makes zanubrutinib. So what about other treatments for relapsed Waldenstrom's? And we can actually go through this relatively quickly because there are no studies, really. There are just drugs that have been used in other diseases that have been tried in a small number of patients with Waldenstrom's. So bortezomib is a proteasome inhibitor. Proteasomes are complexes that are like garbage disposals. They break down proteins. And the problem in some of these lymphomas is that some of the proteins that the proteasomes are breaking down are actually good proteins, so the proteins that promote cell death. And so if you can block the proteasome or inhibit the proteasome, then you have more of these, what we call pro-apoptotic proteins that are circulating around, and therefore that cancer cell is sensitive still to chemotherapy. Multiple myeloma is a disease that's a sister disease to Waldenstrom's, as you probably know, and proteasome inhibitors are a mainstay of treatment in multiple myeloma. These are some clinical trials using bortezomib, which is the first proteasome inhibitor. And so I'll just go through the table very quickly. So the first two studies were combinations of bortezomib with dexamethasone and rituximab. Both of those studies in patients that were treatment naive, no prior treatment. And again, you can see very high response rates, very high VGPR rates, and 66 months of progression-free survival, or 42 months in those two different trials. So that combination, bortezomib, dexamethasone, and rituximab, actually is a recommended frontline combination in the United States. The last two rows in that table are bortezomib with rituximab alone, and in that case, they didn't work all that well. So bortezomib rituximab is not really an available choice. The problem is that there is no funding for bortezomib in Ontario, and I think in most provinces in Canada, it's not funded for Waldenstrom's. And so BODR is a preferred regimen in the United States, but it's not really a preferred regimen in Canada. Venetoclax, again, we're borrowing now from CLL. So venetoclax is a BCL2 inhibitor. Sorry, there's a typo in this first bullet point. BCL2 is an anti-apoptosis protein. Apoptosis is programmed cell death. If you have anti-apoptosis, then you're preventing cells from dying. So your cancer cells, they don't die normally. That makes them resistant to chemotherapy, for example. But blocking BCL2 with a BCL2 inhibitor restores normal apoptosis, so those cells die appropriately. And venetoclax has been one of the two revolutions in CLL. Venetoclax with ibrutinib are the two sort of classes. So how about in Waldenstrom's? How well does it work? But we only have one small trial on the next slide. 32 patients with relapsed Waldenstrom's. You can see a VGPR rate of 19% and 80% progression-free survival at 2 years, which actually is very good. But this is early. This was just published last year. It's only in 32 patients with relapsed disease. So venetoclax hasn't really gained hold yet, but certainly it's one of those drugs that when you're running out of options, this may be one for your doctor to try to get for you. What about other treatments in relapsed Waldenstrom's? So the first three classes here, the PI3K inhibitors, the immune modulators, and the histone deacetylase inhibitors, I'm not going to go into them, how they work, but these also are drugs that have been developed in lymphomas, in other lymphomas besides Waldenstrom's, probably have been studied in a handful of patients with Waldenstrom's. Some people have responded, but there isn't really data to say these are good options. So these are sort of in that category of, what to try when there's nothing else to try, if you can get access to them. And getting access to these is very difficult. In fact, the PI3K inhibitors have been taken off the market because of toxicity. Immunotherapy includes checkpoint inhibitors, CAR T therapy, and bispecifics. I'm going to leave this in case somebody asks about these in the question period, because I know we're running low on time. And stem cell transplant, again, I'll show a diagram at the very end which shows you where I think stem cell transplant fits in. So what about clinical trials in Canada? So right now there are 3 active trials in Canada. There's the BROM study, which is a phase 2 study, which includes bendamustine rituximab plus acalabrutinib in previously untreated patients. You can see that there are various cities across the country that have that trial open. The second study is the Merck 1026-003 study. That's nemtabrutinib in Waldenstrom's patients. These are patients who have relapsed after ibrutinib. You can see a fewer number of places where they're happening, including Ottawa. And then the third study is a phase 1 study of a BTK targeted protein degrader. I'm not going to get into the mechanism of that. It's only available in Calgary right now. So the BROM study, again, it's bendamustine rituximab and acalabrutinib. It's a phase 2. It's a Canadian study, so it's only being done in Canada. This next bullet actually is updated. There's now 49 patients out of a planned 59 patients. The reason for trying it is that we know that ibrutinib plus rituximab in the PCYC 1127 study showed a VGPR rate or better of 23%. Bendamustine rituximab showed a VGPR rate or better of 23%. We can combine them safely. We can give bendamustine and rituximab for 6 months and give acalabrutinib for 1 year. If we do that, can we really improve the VGPR plus CR rate, and therefore get what we call deeper and longer remissions? And we're already seeing that this is working. This trial is not finished yet, but interim results are being presented at the American Society of Hematology meeting this year in December. And the VGPR rate plus CR rate, I can tell you, is much higher than the 23%. So the combination is working. The nemtabrutinib trial, this is actually, it's a large trial of over 200 patients, but it's including 40 patients. No, I'm sorry, 25 patients. Sorry, there are 25 patients that have been treated. 60 patients with Waldenstrom's will be included on this study. And this is a non-covalent BTK inhibitor, which I'll show you in the next slide how that works. So here on the left, we have ibrutinib, acalabrutinib, and zanubrutinib, and they work in this pocket. So they're covalent inhibitors. Covalent means that when they bind, bonds form so that the drug stays in that pocket, right? But you can see that picture of that BTK at C481. If that pocket mutates, then that drug is not going to fit in the pocket anymore. It's no longer going to work. So on the right, we have pirtobrutinib as an example. It's a non-covalent drug that doesn't bind in the pocket. So if C481 is mutated, in other words, if the shape of the binding pocket changes, the pirtobrutinib will still work because it's not dependent on the shape of the binding pocket. And so the goal of pirtobrutinib and nemtabrutinib is that you have a drug that now doesn't care if the Waldenstrom cell has developed a mutation that makes it resistant to ibrutinib. These drugs should still work. And we do have some data already showing that that is the case. I'm just going to skip this slide for the sake of time. So what's going on outside of Canada? So there are 3 active trials within Canada. There are 53 trials actively recruiting patients worldwide. These are just a partial list, but what you can see is where things are going. So that second line, Rainbow, that's a study of chemotherapy RCD versus ibrutinib and rituximab. So that's a phase 3 study. If that study shows that ibrutinib plus rituximab is better than RCD, then that would be justification for CADTH to fund the combination ibrutinib rituximab in frontline. So that's an important study. It's being done in the UK. It's not being done in Canada, but we will be looking closely at the results of that. But every other study, what you can see is now we're combining classes of targeted agents. And it doesn't matter which ones they are, just the point is that they're adding one targeted agent to another, and they're going to look at how well they work together. Okay, I just want to go through this quickly. This is what people don't really realize, the process for how we access drugs in Canada. So going from left to right, you could number those boxes 1 to 5. So the first step is that a drug company does a clinical trial, and they believe that the clinical trial proves that the drug is effective and safe. So they apply to Health Canada for an indication. Health Canada reviews the data from that clinical trial and any other data that's available. If they believe that the drug is effective and safe for a particular cancer, then they'll say, okay, we'll provide notice of compliance, meaning that we've reviewed all the data, we believe it, it's valid, the drug works and is safe. So that's the first step to get Health Canada approval. The second step, though, is just because a drug is Health Canada approved doesn't mean that it's going to be paid for. So the CADTH, which is the Canadian Agency for Drugs and Technology in Health, they do something called the Pan-Canadian Oncology Drug Review, or PCODR. So that's a panel of medical experts that get together and look again at the trials, but they don't just look at the safety and efficacy, they look at the cost efficacy, and they look at the population and see, is there other treatments in that population that are already cost effective and work very well? So do we really need to encourage the provinces to pay for that drug? So they make a recommendation, are we going to pay for this or not? I'm just getting a message that this is covered in tomorrow's session. So that's great, I didn't realize that. I can go through it much more quickly. So Health Canada approves, CADTH or PCODR recommends you should fund this in the provinces, and then it goes to a national negotiation committee that comes up with the price. That price is going to be the same price across the country, and then that price goes back to each individual province, and each individual province can say, we can afford to pay to fund this drug or not. And it's only if the province agrees that the drug works, it's got a recommendation, and it's affordable, then they put it on the public payment plan. And I talked about patient support programs. So usually what happens is that either from the moment that Health Canada approves the drug, or from the moment that CADTH recommends that the drug be funded, from one of those 2 start points, the company will make it available to patients free of charge through a patient support program, and that will continue up until the time that the province says, yes, we'll pay for it. And then they transition the funding of the drug over to the province. So, I mean, this is an altruistic thing that drug companies, for all you can talk about drug companies, and there's lots of bias there for sure, but this is a good thing that they do. They make their drug available before it would otherwise be available. So what can be done when there's nothing left to be done? So I think, if you're in a situation where you've had many treatments before for your Waldenstrom's and it doesn't seem like there's anything else, these are the questions that you need to ask your hematologist. If I want to get panobinostat, for example, Is it available through my private insurance? Is there a patient support program available from the company? If neither of those are the case, you can apply to your province for a case-by-case review where the province would then pay for it, potentially if you can prove that there's data that's effective and you've exhausted all other options. And the Health Canada Special Access Program is for drugs that are not yet Health Canada approved, but they're available in other parts of the world. And this is essentially asking Health Canada to import the drug, and then you'd have to get the company to provide it on the patient support program. And then I don't know if you know about clinicaltrials.gov, but this is the place that you can go to look for clinical trials. And it's a very easily navigated website where you put in Waldenstrom's as your keyword disease, and then you click the checkbox for actively recruiting trials, and then you can put a location of Canada, and you can search and you can find out that there are 3 trials available for Waldenstrom's patients in Canada, and it'll tell you which sites are present. If you can't find something for you in Canada, then you can switch that location from Canada to the United States. And if you're living in Eastern Canada and there's something going on in Boston and you have the means to get there, then I think that can be a consideration. This is my final slide. So this is what I propose as a current treatment algorithm for patients with Waldenström. So I think first-line treatment is still chemoimmunotherapy. Bendamustine or rituximab has proven itself as a very effective treatment. 6 months of therapy gives 6 years of remission. On average, some people will go 10 or 15 years without needing further therapy. Now I've got 3 branches. On the top branch, those are people that have a very long remission. After first-line chemoimmunotherapy, I think they should have chemoimmunotherapy in second line. And that can be BR again, it can be RCD, or I think that BORD is a very good option for those patients. If they had maybe a 2-year remission, then I would say that's disappointing. Those people should get a BTK inhibitor in second line. And by COV means covalent, so that's ibrutinib, acalabrutinib, or zanubrutinib, and I would say zanubrutinib would be the one of choice. If you have a very short response to your first-line therapy, then you are a very high-risk patient, unfortunately. And those are the patients that I think need the highest risk-reward treatments, and that's stem cell transplant. And then you can sort of follow this algorithm along, and I think you'll have access to these slides afterwards, so I won't go through them exactly, but these are sort of the sequences that I would recommend in third treatment and beyond. With that, hopefully I didn't go too long, and we'll have some time for at least a few questions. Hi, Ron.
Hello, thanks. That was a lot of ground to cover, Dr. McDonald. We do have some pre-submitted questions. We have a few minutes, I think, for questions. I've got them by topic. Zanubrutinib, you said it's funded this year in Ontario. I know that since February it's been funded in Quebec. What do you know about other provinces?
So I don't actually know, I'll be honest with you there, but I think most provinces by now it's been funded. It had a positive CADTH review almost 2 years ago. It's gone through the Pan-Canadian price negotiation, so it's been sitting there for the provinces to add to their formulary for months. So I don't know, but I think by now most provinces have it.
There was a few questions about BR because it's so universal. Patients report side effects during treatment, including fatigue, impaired immune systems. How long do these symptoms typically last post-treatment?
It's a very good question, and everybody is different. And as you know, some people go through BR and don't have any symptoms. They tolerate it very well. I think in general, if somebody is having symptoms at the end of treatment, I tell them, you can expect that probably it's going to be 1 to 3 months for many of those symptoms to subside.
Okay. Do vitamins and supplements help the immune system recover?
Yeah, it's a good question, and I think the answer is that we don't know. I get a lot of questions like this about things that I try not to demonstrate a bias against them, because that's not really what it's about. I think that we all should be working together. But for me to say zanubrutinib works, I know how to analyze the data that zanubrutinib works, right? And it's really quite regulated. But for somebody to say that high-dose vitamin C works, that same degree of rigor in clinical trials is just not there. So if you ask me, does vitamin C work to improve the immune system? My answer is, well, I think that there's probably data that shows that it works in a test tube and in a petri dish, but I don't know that actually means that somebody who gets vitamin C is going to have less risk of having an infection. I don't know.
Okay. There was a single center study that showed that 4 cycles of BR was as effective as 6 in terms of overall survival and progression-free survival, but a more recent multinational, multi-center one, retrospective studies seem to show that 6 cycles gave deeper, longer responses as a first-line treatment, but 4 cycles seem to be sufficient for relapsed patients. Do you have any thoughts on number of cycles of VR?
Yeah, I mean, so first of all, there's no randomized controlled trial of 6 cycles versus 4 cycles that's limited to a population of patients with Waldenström's. I mean, that just doesn't exist. There are lots of single center studies looking at 4 cycles and saying, well, in our population of patients getting 4 cycles, the remissions lasted X long. I think one of the points that was made in the previous discussion was that Waldenström's is not curable. And yes, we want treatments that are going to give the best response rates, the longest remissions with the least toxicity. But because it's not curable, I think pushing the limits of chemotherapy in somebody that's having side effects may not be in their best interest. So I have lots of patients who have had side effects from bendamustine, and we had to stop after 3 or 4 cycles. And those patients have still had very long remissions. That's not randomized, that's anecdotal. But I think we all have to sort of realize it's not curative treatment, so don't push the envelope in somebody who's having toxicity.
Okay, you expressed your clear reservations about rituximab as a monotherapy and also reiterated the current recommendation against maintenance. Are there subsets of WM patients for which rituximab monotherapy or maintenance would be appropriate?
Yeah, so for the maintenance part, no, but I'll come back to that in a second. But single agent rituximab, I think, is, like I said, it's a 50% response rate and remissions last 2 years. I think if you have somebody who is older and more frail and has a lot of other medical issues where they're going to be at increased risk of toxicities with chemotherapy, we often go into that very nervous about giving bendamustine. That's the type of patient where I think single agent rituximab may be a good treatment. Give it now for 4 cycles. And when they relapse in 2 years, give it again for 4 cycles and just try to keep them going that way. But truly, it's just not a very effective thing.
Thank you. Okay. Under what, in what circumstances would someone switch from ibrutinib to zanubrutinib? And in what circumstances would they not?
Yeah, good question. So lots of people are on ibrutinib and have been on it for a long time, made available to them through the patient support program from Janssen. And if they're on ibrutinib, it's continuous therapy. It's intended to be until progression. If they're having side effects on ibrutinib, sometimes switching them from ibrutinib to zanubrutinib can make those side effects go away. So I think that would be an important reason to consider switching somebody. I think that you have a randomized trial that shows zanubrutinib works better, but I wouldn't use that as a reason to switch somebody who's already benefiting from the ibrutinib, especially now that we're going to have nemtabrutinib and pirtobrutinib for those people who truly become resistant to ibrutinib. If you're resistant to ibrutinib, you will be resistant to zanubrutinib. That would not be a situation to switch.
Okay. How often should patients on watch and wait be monitored?
Yeah, it's a good question. I mean, I think we do things routinely, and typically in my own practice, I'll see somebody on watch and wait every 3 months for the first year or so. And then it can become really a little bit more relaxed than that. It's very rare that I'll be following you, Ron, and I'll be seeing you every 3 months, and then you'll come to my clinic and you'll say, yesterday I developed neuropathy, and I'll say, well, today you need treatment, right? What happens in watch and wait is that people develop symptoms between their scheduled visits, and they call the office and they say, I've got this new thing. I think it might be my Waldenström's. Do you think it might be my Waldenström's? I say, come on in, we'll see you. So even though their appointment might have been scheduled 6 months away, they're going to come in early. So it's a little arbitrary, but generally speaking, 3 months for the first year, and then maybe every 6 months after that.
Well, you know, David, I was just at the Patient Ed Forum in Amsterdam, and Dr. Dessau and a lot of the other European specialists are now using the term active monitoring instead of watch and wait. And I really love that, just from a psychological point of view for the patient, that we're not on the sideline, we're actually involved. And so by reporting the symptoms to you when there's changes, then we're working together.
Yeah, I exactly agree with that.
Okay, well, thank you so much for your brilliantly clear presentation, covering a lot of ground as usual. We will now be leaving the main stage and moving to the networking room for an opportunity to get to know each other a little better. please return to the virtual venue lobby by clicking on the lobby button on your screen at the top, and join us in the networking room, and then click on join. And if you need any assistance, you can click on the help desk, and I'm looking forward to meeting some of you in the networking room. So we'll see you there.